So welcome to the Paediatrics induction today. So I'm going to talk you through Darlington and Durham sites, and if there's any problems I will be asking one of my colleagues behind the counter. So the main thing is that, as we've said before, we're a very friendly department. We're all really approachable and we like to be that way, so we want you guys to get the most out of this placement, but there are things that need to happen in certain ways in order to really just benefit our children who we look after. So at Darlington and Durham work quite similarly. We have a mixture of what we call traditional consultants and resident consultants. So the resident consultants are consultants who work similar to to registrars in that they do some medical, some middle grade shifts. So you might actually be on nights with a resident consultant. And it's quite nice for you guys because it means that you get to do some work-based assessments, you get to learn directly from a consultant in a more acute environment than you do on a day-to-day basis. So at Darlington, I think now we've actually got quite a few more resident consultants than that says there, so I think there are about 5 or 6 now. We also have some community consultants, particularly for the F1s. That's where you'll meet your community team and start to do some more community clinics. We do have specialist nurses, and they're a really good source of wealth and knowledge. It's really important that you do introduce yourselves to them whilst you're here. Try to get to know about the areas that they specialise in. For example, the diabetes nurses, they'll tell you all about the diabetic pumps, and also they'll probably give you a bit more of an insight into the life of a child who has a chronic condition, so that you're not just getting the picture of that child coming into the ward and being unwell at that particular time. You will have registrars who work with you. On both sites we have different numbers of registrars, but you will have a registrar. Like everywhere, we are a bit short on all our rotas, but you'll probably see that we all work together to try and patch those gaps up as efficiently as we can. So again, and also, sorry, in addition to the registrars, you've got the APNPs, so the Advanced Paediatric Nurse Practitioners. They're not on this particular site, but I'll talk about them anyway. So they work in between at SHO and registrar level. I think for you guys, they're absolutely brilliant, because that's where some people feel that they're less formal than approaching a registrar, and if you've just got a niggling doubt, they're the people who can help you. They also can see children and discharge them, so that's why they kind of work in between both levels. And then, as you probably have seen on your rotas, you're a mixed bunch, so you'll have a specialty trainee, GP trainees, and you've got foundation trainees working together. But the good thing is that you all bring something different to the rota. You'll probably find the GP trainees have got previous experiences because they're at a different stage. Quite a lot of them have reached the GP registrar level, but again, they're quite helpful in that they can tell you other things. For example, like they've done obs and gynae before, so they might be able to explain to you a bit more about the maternal things that you need to know for any babies. And then you've got the nurses on both wards. They're very friendly, and you've also got the matrons. So Janet and Angela are the matrons, and they work across both sites, and you will meet them in your travels as well. So those are just a list of consultants, and I've said that it's very similar in Durham as well. And as I said before, we like our photos in Durham, so this is what will happen to you lot as well. You'll have your photo taken and displayed. So the way it works is you will always have a paediatrician of the week. So that's the POW, or what was known in Darlington as POW 1. The POW essentially covers from Monday to Friday, 9 to 5. So they're in charge of the ward, and they're your source of continuity. Sometimes it doesn't always happen that because sometimes some consultants are working part-time, and so the week gets a little bit split up, but we still try and maintain as much continuity as we can. Then you also have a second consultant on from 9 to 10, and they're there on the shop floor. They're there to help you, and if you have any questions, you can approach them. They tend to cover all the emergencies, so the admissions, the special care baby unit, any neonatal emergencies, and they do child protection. Now in Durham and Darlington it's slightly different in that the POW also covers the day unit, whereas in Durham the POD will cover the day unit. From 5 to 9 you then have a consultant who's on call from home. So if there's an emergency, they can be called in, but otherwise it's you and the registrar or you and the resident consultant who's on it in the hospital. And we have a middle grade person 24 hours, so you'll have someone who's on with you from 8:30 in the morning till 9 o'clock at night, and then the night registrar will be on, or the night resident consultant will be on with you. Okay. Does anyone have any questions? Oh, going backward. Okay, so the teaching programme, we're trying to, in Darlington, we're just making a few changes to try and establish the teaching programme. So actually this slide is out of date, but once it's up and running, Dr. Eason-Polly will go through all of that with you, but it'll be a very similar format. We're aiming to do teaching in the mornings. It's part of your contract, so it will be within your contracted hours, okay? It's really important that you do know that, because we like you to turn up on time, and just to remember that you are contracted for it, because what we have found is that people are turning up late, and consultants are usually on time, but the issue with that is the teaching is for you, it's not really for us. Yes, we benefit and we learn, especially by discussing things with all of you, but we need you guys to get the most out of teaching. So if it starts at 8:30 and you come at 8:45, then you've missed quite a lot of the session already, and it is within your contracted hours as well. We have a trainee presentation here at Darlington, and I think usually there's a list up which tells you which trainee's presenting, and so that if you ask Sunil, he'll help you and tell you which day you're presenting. And usually that's a case presentation with an explanation of the condition. And I think now the other thing that's trying to re-establish as well is A&E resus teaching, which will be in the form of a simulation. So we're trying to do that across both sites. But I think it'll start first in Darlington, just because the A&E team have more resources here to do that first. On the last Friday, or the fourth Friday of the month, you have a perinatal meeting. That's again an opportunity for you guys to present a case. You'll present the facts from the baby side. A registrar might then present some of the condition behind that baby. The obstetricians would have presented first, and they would have present their facts about the mum and the condition behind the mum. And then we've got something called a SAGE meeting. Essentially this is a meeting that happens every fourth Wednesday. It's actually for consultant CPD, but we invite all the trainees to come as well. So if you can come to it, it's a really good day. You can see that you sort of see consultants in a different way, because we're probably a lot more relaxed when we're at CPD, but you'll also learn some really interesting topics about paediatrics and some governance issues as well. Then on a Wednesday morning here, whereas on Durham it's a Friday morning, we have special care grand round. So that is where all the consultants who are present within the hospital and all the doctors will go on the round to see all the babies in special care. The SHO who has been allocated to special care for that week will present those babies. You will know those babies inside out by the time by the time grand round comes. We have sheets called yellow sheets, or they're essentially just a pro forma that you fill in ready for the grand round. And they'll have things like the baby's gestation, how old they are now, what are the current issues, what are the past issues, what were their bloods and other investigations that they've had. Any problems, you just ask your registrar or the special care unit nurses, because they are so specialised, they're experts in what they do, and they will help you. Sometimes you can feel that they know their unit very well, they're quite protective of it, but it's because of their expertise. So they're a great source, again, to learn from. And as they get to know you, they'll let you become slowly more and more independent in the special care as well. Okay. Durham, we have 3 days a week of teaching in the mornings, so that's Tuesday, Wednesday, Thursday. On Tuesday and Thursday we tend to have case presentations or scenarios, journal club, and sometimes we have audits as well, so we're starting to bring in more audit presentations. On a Wednesday we have a paediatric, a child protection liaison meeting where we have a social worker and a safeguarding nurse as well, and we discuss cases. Sometimes it does feel a bit like, oh, this is way over my head and I can't really get the grasps of what's going on, because usually it's the consultant who's presenting the case and then the safeguarding nurse and social worker giving their input into that case. If you don't understand something, just ask, because this is also for you guys to know about child protection, and safeguarding is important everywhere. Okay. And then we have the perinatal morbidity mortality on the 4th Friday as well. Handover. Okay, so paediatric handover is really different from any other speciality. We're quite specific about our handovers. We really want them to be in a set format. We want to know about everybody. It'll be really different to what you're used to, unlike in adult medicine or adult surgery where you might have lots of volume of patients, but only certain patients are really, really sick. Here in PEDS, we need to know about everybody, everyone who's on our ward. The person who hands over is the SHO who has done nights. And the way that we like handover to take place is in the S-bar format. Have you heard of that before? Yeah. Okay. So it just helps everyone it helps handover to be concise, but it also helps the important issues to come through so that you're not just kind of reiterating the whole story again, but we just need to know what are the important facts. It's really difficult if you have a busy night, because it's impossible for you to have had time to have read all the patient notes and then to be ready to present them. That's not going to happen. So the way to do it is you will know the patients that you've seen, you'll know the patients that the registrar has seen overnight, and you'll know about the sick patients on the ward. The rest of the patients, if you, just before handover, the nurses hand over at 7:30, both on the ward and in special care. So somewhere before that time, if you go to special care, and then you catch up with them about the babies and how they've been overnight. And then you do the same for the children on the ward. Because there may have been things that have happened overnight that the nurses have not told you about, but that they've managed to sort out themselves. But we need to know about it the next day, especially when we're going around to see them. There will be, the other thing that's really important is you will probably have pending discharge letters that have accumulated in the daytime that need to be done in the night time, because sometimes that's the time when we get to catch up on them. Ideally, that shouldn't happen. Every child who leaves the ward should have a discharge letter in hand with them, but sometimes during the busy months, that's when things do tend to accumulate. You've come at the time when it's now April to August. Actually, this time in paediatrics is quite nice. You'll have plenty of learning time and you won't get swept away with the winter busyness. But saying that, all hospitals at the minute are experiencing a crisis, and we're not really having spring or summer or anything at the minute. So I think we'll just have to see how that pans out. Any jobs that need to be handed over must be handed over as well. Here at Darlington, you've got something called the L drive, and the handover sheets are on that. At Durham, you've got something called the G drive. You'll all have access to the G drive. The L drive you don't need access to, you automatically get it. But the G drive, I'll set up access for you. And the handover sheets are on that, and they're labelled per day. So we have a morning handover at 9 o'clock after teaching. Then we have an afternoon handover at 4:30, and then you have the evening handover at 8:30. There's usually a consultant present at all those handovers. Sometimes the evening handover there might not be, and that's usually because they're trying to mop up some of the jobs that are existing, or seeing some more patients while you guys are handing over. Anyone want to ask anything about? Handover, we try and make it a teaching opportunity if we can. The problem is that we also don't want to go over your time either, and especially for the night team, they need to get home, so we kind of try and stick to the 30 minutes, and then try and have any other discussions after that. In terms of GP and A&E referrals, we don't say no to anybody, because where children are concerned, it's quite difficult to sometimes know how much expertise the other person has got on the phone with a child, and also what facilities they've got. Some GP surgeries, when they tell you about the saturation monitors, they might only have an adult probe and not a child probe, and it's hard to gauge, you know, how ill a child is. Saying that, if a GP wants to have advice, the registrar can give advice. If they ask you for advice, please pass them on to the registrar. It's important that you note down who's referring, which surgery they're calling from, the number of the patient, because sometimes they don't turn up, and then we start to get worried about them, and we need to know where they've been. Some parents just choose not to turn up, which is fine, but still we need to know what's happened. If you have any A&E calls, so for A&E, you'll get called down for recess. You won't get called down to see children in A&E. A&E team should manage to see their own children. That's when the crash bleep will go off, and then you'll be told to come down to A&E. If you've heard a crash bleep and you're not carrying it, it's also worth you asking, you know, can I go down and see what's happening? Can I give a hand? Because that's when you'll learn more. The way it works at Durham is the GP bleep is held by the SHOs, and the A&E bleep is held by the registrars. Here, I think both bleeps are held by the registrars, and all the calls go through to the registrar. So, in order to clerk patients, similar to other specialities, well, we have a pro forma. It's just because we're quite pedantic about our birth, developmental history, social history, immunisations. We need all of that information. I do it almost every induction. I say, please fill it in, and then I'll find 1 or 2 people who've started in the first 2 weeks who've left that page blank. Don't leave it blank. It has to be filled in. It is really important. And it's not just, you know, okay, they might have come in with an upper respiratory tract infection, but how do you know that they've got 5 half siblings, that they're on the child protection register, and actually they've come in with an upper respiratory tract infection, but they've got a bruise on their shin, and actually, and then when you get into more details, there's more worrying things in the background that should have been known about. So it's really important by taking that history in the beginning. We love our family trees, so please draw them, because there is space on the pro forma for them to be drawn. So we do like to know who's half, who's not, who's step, and who's you know, a birth parent, things like that. So all of that information, we're really pedantic about that. So if you do that really well in the beginning from the word go, then you just keep up that practice all the way through. Make sure you sign off, date, and put your surname and your position as well. The stamp. So the stamp is there to help on the ward round. It's just as a reminder to make sure that we see that we've seen the drug chart, we've seen the fluid charts, we've got the information from the nurses, and you have to put that stamp in every child that is seen on the ward round. So it looks like that once it's in there. Discharge letters. I bet you're all sick of EDL, but you all know how to use it. I think the Trust has made it easier by now for making one discharge letter. We used to have separate discharge letters for specialities, but that's changed slightly now. And the GP must receive a copy within 24 hours. The print button has got much better. So when you now press it, it then jumps to close, so that you know that the GP has now received it. Before, there was actually no way of knowing that. So there have been some small improvements in the EDL. Other learning opportunities, we've talked about these already. The important thing for you is that work-based assessments. So you're in charge, you know what you need. If you need it, just ask. People will do it. All the consultants know how to do the work-based assessments. You've got to remember that we do, because we see so many different trainees, that sometimes we might need a little bit of help knowing how to open up a foundation assessment compared to how to open up a GP assessment. So there are things that we might come and ask you about as well. But on the whole, we know about assessments, we know about SLEs, and you know, we are there to help you finish them. The guidelines, right. I'm just going to come off presentation for a second. So we have guidelines. At the minute we are developing our guideline website. But if you go into the intranet and you go into sites and then into child health, you've then got a neonatal guidance and paediatric guidance. Paediatric guidance is divided up into headings. So if you were looking for a child with bronchiolitis, you'd go into respiratory. If you had anything to do with eczema or chickenpox or anything like that, you would look in dermatology. Okay. This is still under development, so actually when you click in, there's only one set of guidance there. However, if you do need the guidelines, There are two things here, the neonatal index and the paediatric index. So if you click on the paediatric index, so this is a Word document, but it has links in it. And again, it's divided up into systems so that you can see. The guideline that you do need to know a lot about is the urinary tract infection in children. The computer's being a bit slow this morning. So ideally, when you click on it, it'll bring up the guidance for you. What I'll do is, when I do talk about paediatric emergencies, I'll talk to you a bit more about the urinary tract infection. Okay, we might have to leave that one for now. But so basically you should be able to access the guidelines through this. So we have children who come to the ward onto the admissions unit, and but we also have children who, and then you have children who stay overnight and who are admitted. But you also have children who you need to see back a bit earlier than you can in clinic. So therefore they're called ward attenders. So we bring them back to the ward to be reviewed. You're only allowed 3 ward attenders a day, and if you're putting someone in the ward attender book, please make sure that a senior person has given their name to you as that person who's responsible for seeing that child. And just also to jot down the reason for follow-up. After that, they should then have further follow-up in clinic. You'll also hear about a clinic called Rapid Access Clinic. GPs can access this clinic within 10 days, so actually children can get appointments quite quickly. But please do not put a child, or do not advise a GP to put a child into Rapid Access Clinic without speaking to a senior person first. All children get open access, so anyone who comes into the ward and is seen, sent home, so if they've got diarrhea and vomiting, and actually we managed to hydrate them a little bit and they're fine to do the rest at home, they would get 48-hour open access. What I tend to do is not sell 48-hour open access to children who have simple coughs and colds, because they don't really need it. The system is for children who have illnesses that would require them to be reviewed again within 48 hours. There are some children who have chronic conditions and they need more long-term access, and we have a folder with their names in. And it'll tell you in that folder what to do. And there are other children who also have something called health care plan. So it's an educational health care plan. They'll come with that, and that will tell you exactly what to do in any emergencies, or if they have any infections, it'll tell you about the antibiotics that they can have. So you just follow that. We've talked about night shifts already. Bottles, so we have teeny tiny bottles compared to adult bottles. They then go into that brown tube. The brown tube mustn't be labelled, it's the actual bottle itself that needs to be labelled. You can handwrite it, or you can stick a sticker on it. Just make sure the barcode is not on there. Now, so coming back to urinary infections, so the reason why we're quite pedantic about urinary infections is because they can cause kidney scarring. They can do that within 48 hours of you actually getting a urine infection. It's very different from adults. So the way round it is that we microscope the urines. So if we think a child has got a urine, practically every child who comes in with a temperature or vomiting or tummy pain will have a urine sample collected. Babies have something called a Newcastle pad put onto their nappy, and that soaks up the urine, and then the urine is pipetted out from there. It gets dipped, and if they have any nitrites or any leukocytes, or you suspect urine infection, then you'd go on to microscope it, and you'll learn that skill very shortly in the morning. And then the idea is if you see bugs on a microscope, you can treat that infection, because when you send it off the culture to the lab, it's going to take 48 hours. So it's too late if you're waiting for the culture to come back. So during those 48 hours, the child who's had urine sent off has to have that record put somewhere for someone to chase up. So here in Darlington, it's a black folder. In Durham, it's a yellow folder.
We've moved on now. We've got on the computer now. It's an Excel sheet. We just put all the jobs on Excel sheet.
Okay.
So I'll show you that later.
Okay, so you've got your Excel sheet that you can follow them up. When we put the information in, you've got to put in what sample's been sent, when's it been sent, and the contact details for the parents as well, so that when you're phoning, and then it also gives you space for communication. So what have you said to the parents, and if they need antibiotics as well, and if they need to go to the GP surgery to get some more antibiotics. The way the folder is in Durham is if you, for example, today's the 4th, so if you send a sample off today, you're expecting it to be back on the 6th, so you'd file it in the 6th. So then that SHO who's checking those results will know that they're back on that day. Someone needs to check that file every day. And it's not just for urine, it's also for any swabs, any blood tests that might take longer than the time that the child is in hospital for. So anything that takes a week, like PCRs, or, again, they would all go in that book, and then in the date that you'd expect them to be back for. We do have also a nurse-led phlebotomy service. We have a nurse clinic, blood clinic, that you can book children in for non-urgent bloods as well. On the paediatric ward, as I've said before, we need to know about all the patients. You will get patients from other specialities, so you'll get surgical patients, orthopedics, ENT, so we tend to oversee all of them as well. Orthopedics, we probably let the orthopedic team see them mainly, and if they need our help, they'll ask for it. Surgical patients, we see them jointly, so particularly the appendicitis, we'll see them together. Sometimes they need help with writing up fluids and bloods, and then they'll ask you guys for help as well. Okay. And you will be able to help them, though you might feel differently at the minute. Clinics, you've got clinics rostered into your rotas. There are lots of different clinics. My advice is go to the general clinics first if you can, before the speciality clinics, just so that you can learn a bit more about general paediatrics, and then you can start learning about specialities. That's the same in Darlington. If you ask the clinic coordinator, they'll be able to tell you what clinics are on for that day. Child protection. You shouldn't be dealing with child protection. If you have a GP who rings you who says, I've seen this child and I think they've got a mark, I think it might be a bruise, then you say to them, please phone their consultant. And that's all you have to do. Sometimes you will get calls for other things, such as DMV, and then, oh, I think there is a mark, again, just say, please speak to my consultant. We don't take consent for any procedures also sort of any surgical procedures, because we're not responsible for doing them. The thing that we do at Durham is that we do MRIs and sedation. We have a sedation protocol. It's really simple to follow, and you'll prescribe the sedation drugs according to that protocol. But your role is also to just quickly clerk those patients in, so it's a bit like a pre-assessment clerking. Protocol, you'll become more familiar with that. So you'll all get clinical supervisors and educational supervisors, and you should have your educational supervisors already. Please meet with your supervisors within the first 2 weeks of you starting. It's really important that you do, and then try and think about your PDPs. What do you want from this job? So if you have an idea or you've already written them, that's really helpful at the starting meeting. We do have a competency checklist, and I'll email that out to you. It's really more of a practical checklist, and it's quite an old checklist. I think the same checklist was there when I was training, but it's just helpful. It gives you an idea of what you probably need to learn at your level. In terms of study leave or annual leave, so that you basically just email the rota coordinator. So that's me at Durham, and at Darlington it's Dr. Antima Banerjee. So if you just email her, then we'll coordinate your study leave and annual leave. On the whole, there's very little times that I refuse study leave or annual leave. But the main basis is that we need the 3 clinical areas covered. So we need special care covered, we need the ward covered, and we need essentially the admissions and postnatal care covered. Once we've got those 3 areas covered, then you get agreement for your leave. Now that's a bit difficult when there's not enough people on the rota, but we've had these rota pressures for a long time now, and so far I've always managed to give people the leave that they need, and we just try and work our way through it. Or what helps is if you're all very flexible with each other and can help each other as much in terms of your swaps, because then that way, if you're helping someone else when it's your turn, they'll help you. If you are sick, please call on the day that you are sick and speak to the paediatrician of the week or the paediatrician of the day. Do not speak to the registrar, and do not speak to the night SHO and just leave that message. You must speak to the consultant who's on call. You're also meant to notify medical staffing as well, but the important thing is if you could notify the consultant first. If you have been off sick, if you could also email me or Sunil as tutors, because we need to know how long you've been off sick for, and just to check that you're okay when you come back as well. For your teaching days, the rotas allow you to go for teaching days, so don't worry if you need to leave. You just tell the consultant of that on call that day and at the beginning, and then they will allow you to go for your teaching afternoons. I think that's probably... Yeah, so the paediatric drive is the G drive, and I'll show you that in a minute. Audit, so you'll all have an opportunity to do audit. We've got governance leads on both sites, so if you have any ideas yourself that you'd like to audit something, or you want to audit something that you feel will be a bit more helpful towards your area of interest, then we can kind of tailor audits towards that as well. Okay, so that's the whistle-stop tour. Does anyone have any questions?